Welcome back to the deep dive. Today we are undertaking a really comprehensive analysis of one of the most fundamental areas of nursing knowledge, the extraordinary systemic and frankly profound adaptations to pregnancy.
This is such a foundational topic. We're not just, listing biological facts. We're really outlining a total physiological and psychological transformation that has to happen for human survival.
Right.
So for anyone focused on maternal child care, whether you're prepping for an exam or, stepping onto the floor for the first time, mastering this stuff is absolutely non-negotiable for safe practice.
And our mission today is precisely that. We're going to synthesize a critical chapter from maternal-child nursing, really detailing that complex interplay of hormones, anatomy, and metabolism that sustains a healthy gestation. We're going to track the changes system by system, what happens when, and most importantly, why.
The why is the clinical anchor. You have to understand it. These changes are all about supporting and nourishing the developing fetus, and at the same time, preparing the woman's body for the high-intensity work of labor, birth, and then everything that comes after with lactation.
And from a clinical perspective, understanding that normal range is everything. A nurse absolutely has to be able to correctly interpret assessment findings to confidently distinguish between a normal, expected discomfort like, a little swelling or a common heart murmur, and a potential complication.
Like preeclampsia or a DVT.
Exactly. Accurate assessment is just useless without an accurate knowledge of that baseline.
Absolutely. So we're going to proceed systematically. We'll start by building the foundation, diving deep into the physiological responses across all the body systems. Then we'll get into the critical signs used to confirm a pregnancy, detail the whole antepartum assessment regimen, and even touch on the unique demands of multifetal pregnancies.
And then we'll wrap up with the really practical stuff, the nursing interventions for common discomforts and that essential psychological journey to parenthood. Okay, let's unpack this incredible overhaul. And let's start where the earliest signs of growth are found, the reproductive system. The uterus's transformation is easily the most rapid and dramatic organ change in the human body outside of disease.
It is truly staggering.
Yeah.
So before conception, the non-gravid uterus is this small, pear-shaped pelvic organ. It weighs a mere 70 grams, that's about 2.5 ounces, and it has a tiny capacity, just 10 milliliters.
10 milliliters. And by the time a woman reaches full term, what are we looking at? What's the final weight and capacity?
It's a huge jump. We're looking at a muscular organ weighing between 1,100 and 1,200 grams, that's almost 2.5 pounds, with a capacity that expands nearly 500 times.
Wow.
Yeah, it gets up to about 5,000 milliliters. It goes from being a pelvic organ to an organ that takes up most of the abdominal cavity.
So what's the mechanism behind that? Is it just stretching, or is the body actually building more material?
It's both, but it happens in phases. In the first trimester, the growth is mostly driven by hyperplasia.
Which is an increase in the number of cells.
Exactly, an increase in the number of muscle cells, and that's stimulated mainly by estrogen. Then, as the pregnancy moves into the second and third trimesters, you get both hyperplasia and hypertrophy, which is the increase in the size of those individual muscle cells working together to get to that final volume.
And this expansion, it's not random, right? It follows a really precise, predictable path that's just invaluable for nursing assessment. We rely on those fundal height landmarks to track fetal growth and confirm gestational age.
Oh, they're absolutely critical for non-invasive monitoring. At about 12 weeks of gestation, the uterus rises up enough that it becomes a palpable abdominal organ. You can feel it just above the symphysis pubis.
And as you track that growth, what's next?
By 16 weeks, the fundus is roughly midway between the symphysis pubis and the umbilicus. That's a key checkpoint. But the really easy-to-remember milestone, the one you always see on exams, is that the fundus is located exactly at the umbilicus by 20 weeks gestation.
The 20-week mark, that's sort of the halfway point.
Right. It's often used to quickly estimate the middle of the pregnancy.
And I know the fundus just keeps climbing until it hits a real physical limit.
It does. It reaches its highest point, the xiphoid process, right there under the sternum, by about 36 weeks. Clinically, this is really important because that extreme elevation puts the maximum pressure on the diaphragm.
Which contributes to that feeling of shortness of breath.
A huge contributor to dyspnea, yeah, that many women experience in the late third trimester.
But there is a bit of a reprieve for many women, especially if it's their first pregnancy. What happens around 40 weeks?
That's when the fetus descends back down into the pelvic cavity, getting ready for birth. That process is called lightening. And while it might create some uncomfortable pelvic pressure and make urinary frequency come back,
the upside is you can breathe again.
The benefit is immediate relief for the mother's breathing. Exactly. The pressure on the diaphragm is reduced.
Now, beyond just size, the uterus gains this dynamic ability contractility. These aren't the real deal contractions yet, but they confuse a lot of first-time moms.
You're talking about Braxton Hicks contractions. And yeah, there are these irregular, usually painless, infrequent tightenings of the uterine muscle that happen throughout gestation. It's like the uterus is practicing, getting the muscle ready for labor.
And they get more noticeable later on.
Much more noticeable, and sometimes even a little uncomfortable in the third trimester.
So how do we, as nurses, teach a woman to tell the difference between these and true labor?
The key is pattern and intensity. Braxton Hicks contractions, they typically stay irregular. They don't really increase in intensity or duration, and crucially, they often go away or stop completely if you walk around or change position.
Whereas true labor,
True labor contractions are going to intensify, they're going to become regular, and they will persist no matter what you do. That distinction is a central piece of patient education in the third trimester, helping them identify what we call false labor.
and all this rapid growth must demand an incredible blood supply. What are we talking about for uterine blood flow?
It is astonishing. Uterine blood flow increases from its non-pregnant baseline to a massive 1,200 milliliters per minute in late pregnancy. And this is just non-negotiable. This blood flow is what supports nutrient and oxygen delivery and the critical removal of waste products through the placenta.
Okay, let's look at the anatomical changes just below the uterus, the cervix, vagina, and ovaries, which actually give us some of the earliest physical signs that a pregnancy is underway.
Right, so the cervix is highly sensitive to all these hormonal changes. Estrogen causes this significant hyperenemia, that's congestion with blood in the pelvic organs.
And that congestion results in a color change, right?
A very characteristic bluish-purple discoloration of the vaginal mucosa and the cervix. This finding is called Chadwick's sign, and it's recognized as a very early presumptive sign of pregnancy.
And what about the change in texture? I remember learning the nose-to-lip analogy for that.
That's Goodell's sign, the softening of the cervix. So normally a non-pregnant cervix feels firm, kind of like the tip of your nose. But due to decreased collagen and increased hydration, the pregnant cervix softens, and it feels more like your lips or an earlobe. A practitioner notes that shift during a bimanual exam.
And at the same time, the cervical glands are doing something pretty important,
They are. They proliferate and secrete this thick, tenacious mucus.
which forms that protective barrier.
Exactly. It's the mucus plug. It fills the cervical canal, and it acts as a sterile barrier to block bacteria from ascending from the vagina into the uterus, which protects the fetus. When that plug is expelled, often with a little bit of blood from capillary tearing, that's what's known as the bloody show.
Which is often a sign that labor is starting or the cervix is dilating.
Right, a sign of imminent labor.
Now, focusing on the vagina, many women report increased discharge. What's happening physiologically to the environment down there?
Well, the vagina and vulva see increased vascularity and thickening, which is preparing the tissues for passage during birth. The discharge, which is called leukorrhea, it increases and becomes highly acidic.
And that acidity is a defense mechanism.
A crucial one, yes. There's a bacteria, Lactobacillus acidophilus, that acts on the glycogen stored in the vaginal epithelium, and it produces lactic acid.
That acidic environment is protective, generally, but it has one major clinical side effect we have to warn patients about.
Right. That acidic, glycogen-rich environment is, unfortunately, the ideal condition for Candida albicans to grow. So, vulvovaginal candidiasis, or yeast infections, are significantly more common during pregnancy. Nurses should be ready to talk about safe management for that.
Okay, finally, the ovaries. We know ovulation stops, but what is their critical early function?
So the high, constant levels of estrogen and progesterone, they inhibit FSH and LH, so the ovarian cycle just stops. But for the first 6 to 7 weeks of pregnancy, the corpus luteum, that's the remnant of the follicle that released the egg, is critical.
Why is that?
Because it's what secretes the high levels of progesterone that are required to maintain the endometrium, at least until the placenta is developed enough to take over hormone production. Progesterone is really the master hormone of pregnancy.
Okay, shifting upward to the breast, the preparation for lactation starts very early, often with just tenderness or tingling.
That's all hormonally driven. Estrogen stimulates the growth of the mammary ductal system. That's like the transportation network for the milk. At the same time, progesterone promotes the growth and development of the lobes, lobules, and alveoli, which are the actual milk-producing tissues.
And visually, what are some of the common changes we see?
Well, increased vascularity is pretty apparent, and the nipples and areolae darken quite a bit due to hyperpigmentation. The tubercles of Montgomery, those are the sebaceous glands in the areola, they become much more prominent. They actually secrete a protective, lubricating substance.
And the preparation is so advanced that components of milk start being produced months before the baby is even born.
Yeah. Colostrum, which is that thick, yellowish, antibody-rich pre-milk fluid, can be present as early as 12 to 16 weeks of gestation. It's important to note, though, that the huge surge in estrogen and progesterone during pregnancy actually suppresses the final conversion to mature milk until after the placenta is delivered.
Now, of course, with that significant rapid growth, you get tearing in the connective tissue.
Right, which results in strag gravidarum, or stretch marks.
So the changes in the reproductive system demand this immense compensatory response from the cardiovascular system. The body has to supply two metabolic systems, and this is where we start seeing the most profound quantitative changes.
This system really does take on the heaviest load. Anatomically, the heart gets pushed up a bit, and to the left by the diaphragm as it elevates. The muscle mass might increase slightly, just reflecting that chronic workload.
And what's important for nurses to know about heart sounds?
That altered heart sounds are the norm. A splitting of the S1 sound, maybe the presence of an S3 sound, and even a systolic ejection murmur are found in up to 95% of pregnant women. These are things that often resolve postpartum.
Let's talk about the single biggest change, which is the volume. I mean, we're not adding a small cup of fluid here. We're fundamentally changing the system's capacity.
It's a huge change. We are looking at a total blood volume increase of 40 to 50% above the pre-pregnancy state.
40 to 50%. Wow.
Yeah, and this is accomplished by a progressive rise in plasma volume, which goes up by 40 to 60% and happens earlier in gestation. The red blood cell, or RBC, mass also increases, but only by about 20 to 30%.
And the clinical takeaway from that disparity is huge. The phenomenon we call physiologic anemia of pregnancy.
Correct. It's often called pseudoanemia. Because the plasma volume increase outpaces the RBC mass increase, the blood is essentially diluted. So this results in naturally lower measured levels of hemoglobin and hematocrit, even when iron stores might be perfectly adequate. It's a dilution effect, not necessarily a true lack of red cells.
So how does a nurse, practically speaking, tell the difference between this normal dilution and a true concerning iron deficiency anemia that needs aggressive treatment?
We have to rely on specific thresholds from clinical guidelines. True iron deficiency anemia requires treatment if the hemoglobin falls below 11 GDL or the hematocrit is below 33% during the first or third trimester.
And it's a little different in the second trimester.
It is, because that's when the plasma volume is at its peak dilution, so the thresholds are slightly lower, hemoglobin below 10.5 GDL or hematocrit below 32%. This is why iron supplementation is so common. We have to support that RBC mass increase to meet the body's accelerated demand for hemoglobin.
Okay, moving from volume to coagulation, the blood itself becomes sort of hyper-prepared for trauma.
Pregnancy induces a profound hypercoagulable state. Key clotting factors like fibrinogen, which is factor 1, and factor 7, ADItes, and eggs, they all increase significantly. And at the same time, the body's natural ability to dissolve clots, fibrinolytic activity, it decreases.
That sounds inherently risky for the mother. It seems like it would increase her risk of clotting. What's the evolutionary trade-off there?
It is an evolutionary masterstroke. This state provides critical protection against the massive hemorrhage that happens when the placenta separates from the uterine wall during the third stage of labor. Without this hypercoagulable state, postpartum hemorrhage would be far more common and far more fatal.
So the trade-off is?
The trade-off, like you said, is a heightened risk of thrombus formation. It makes conditions like deep vein thrombosis or DVT a really serious concern, especially when you couple that with the blood stasis that occurs in the legs.
We also see shifts in white blood cells, or WBCs.
Yeah, the WBC count typically ranges between 5,000 and 12,000 during pregnancy. But during the stress of labor and the immediate postpartum period, these counts can just surge dramatically. We're talking up to 25,000 or even 30,000.
And that's considered normal.
It's a normal physiological leukocytosis. But the nurse has to be aware of it so they don't immediately assume there's a raging infection based just on a high WBC count right after delivery.
Okay, let's turn to hemodynamics. Cardiac output, the volume of blood pumped per minute, it just soars.
It really does. Cardiac output increases by up to 50% over the non-pregnant state. And what's fascinating is the speed half of that total increase is achieved within the first 8 weeks of gestation.
The first 8 weeks, wow, and what's driving that?
The primary driver is the increased stroke volume, the amount pumped per beat, with a secondary increase in heart rate of about 15 to 20 beats per minute.
Given that massive increase in volume and pumping power, Why doesn't the blood pressure just skyrocket?
That is the key compensatory mechanism. It's the drop in systemic vascular resistance, or SVR.
Right.
The vessels relax. This vasodilation is caused by the systemic effect of progesterone, by the presence of this new, extremely low-resistance uteroplacental circulatory unit, and, the need to dissipate heat from the body's increased metabolism.
So the lower resistance balances out the higher volume.
Exactly. It means the BP usually stays stable or might even slightly decrease mid-pregnancy.
This stable BP, however, is critically dependent on position, which brings us to a crucial patient safety point that every nurse has to memorize.
This is absolutely non-negotiable knowledge. Supine hypotensive syndrome. In the second half of pregnancy, if the woman lies flat on her back, or supine, the sheer weight of the gravid uterus partially compresses the large vessels, specifically the inferior vena cava, and, to a lesser extent, the descending aorta.
And the clinical consequence of that is?
Compression of the vena cava significantly reduces the venous return of blood to the heart. And reduced venous return leads directly to reduced cardiac filling, which causes a sudden, sharp drop in cardiac output and blood pressure.
So what does the woman feel?
She rapidly experiences symptoms like faintness, pallor, dizziness, agitation, profound nausea, and potentially even syncope.
So if a nurse sees this happening, what is the immediate, non-negotiable intervention?
Immediate lateral positioning. You have to advise the woman to rest in a side-lying position, ideally the left side, but either side is better than supine. Or you can place a wedge or a pillow under one hip to displace the uterus off those major vessels. This simple move restores venous return almost instantly.
Correcting the hypotension and making sure the fetus gets enough blood flow?
Exactly.
Okay, finally, where does all this extra blood flow actually go?
The circulation shifts dramatically. The lion's share, of course, goes to the uteroplacental unit. But we also see increased flow to the maternal kidneys to clear waste, to the skin for heat dissipation, and to the breasts, which causes that engorgement.
And there's a mechanical issue, too.
Right. Importantly, the weight of the uterus causes this mechanical obstruction of the iliac veins and the vena cava in the pelvis. That leads to venous stasis, dependent edema in the feet and ankles, and it contributes to the development of varicose veins and hemorrhoids.
Let's transition from the pressure cooker of the cardiovascular system to how the body handles oxygen exchange and waste removal, starting with the respiratory system. Oxygen consumption jumps 20%. How does the body compensate for that?
The body compensates mainly through hyperventilation, but it's not breathing faster, it's breathing deeper. The tidal volume increases by 30 to 40%. And the mechanism for this is twofold. It's hormonal and it's mechanical.
Okay, let's talk about the hormonal effect first. I'm guessing this links back to our hormone of pregnancy.
Progesterone is the star again. It acts as a smooth muscle relaxant, so it decreases airway resistance. But more subtly, it increases the sensitivity of the brain's respiratory center to carbon dioxide.
What does that increased sensitivity do?
It means the woman maintains a slightly lower partial pressure of CO2 than normal, and this leads to that common symptom, the heightened awareness of the need to breathe. It often feels like shortness of breath, but it's actually that hormonal drive to increase gas exchange.
And then estrogen causes some chaos in the upper tract.
It really does. Estrogen increases vascularity and causes edema throughout the entire upper respiratory tract. This is what's responsible for all those common discomforts like nasal and sinus stuffiness, chronic congestion, frequent nosebleeds, or epistaxis.
It can even change your voice.
Sometimes, yeah. It can cause temporary voice deepening or a feeling of fullness in the ears due to eustachian tube swelling.
Mechanically, the uterus pushes the diaphragm up 4 centimeters. How does the rib cage compensate so she can still breathe deeply?
The body adapts beautifully. So while the diaphragm is elevating, the hormone relaxin and other factors cause the ribs to flare outward. The substernal angle widens, and the chest circumference actually increases by 5 to 7 centimeters.
So the breathing shifts.
It shifts from being predominantly abdominal to more thoracic, or chest breathing. This ensures that lung capacity is maintained or only minimally compromised, even at term.
All right, let's move to the gastrointestinal or GI system, starting right at the beginning, the mouth.
So we see hyperenemia of the gums due to estrogen, which makes them really sensitive, prone to bleeding, and it increases the risk of gingivitis. Some women also experience tyolism, which is excessive salivation.
What causes that?
It might be linked to starch consumption or just decreased swallowing because of persistent nausea. And we have to take a moment here to debunk an old wives' tale.
The teeth.
The teeth. The fetus's calcium needs are met by increased maternal absorption from her diet, not by leaching minerals from the mother's teeth. Teeth do not lose calcium during pregnancy.
Good to clarify. Now, the GI tract becomes one of the biggest sources of daily discomfort, heartburn. Why is pyrosis so universal?
It's the perfect storm of relaxation and displacement. Progesterone relaxes the lower esophageal sphincter, or LES, that's the muscle designed to keep stomach contents down.
And at the same time,
The growing uterus is pushing the stomach upward and outward. So you have a relaxed, displaced stomach that is highly susceptible to reflux, allowing acidic gastric contents back into the esophagus and causing that severe burning, or pyrosis.
and that same progesterone relaxation affects the rest of the tract, which causes another universal discomfort, constipation.
Yes, gastric tone and intestinal motility decrease significantly. Now, this slowdown is functionally a good thing because it increases the emptying time, which allows for better, more complete absorption of essential nutrients like calcium, iron, and glucose.
But the trade-off is,
The trade-off is that slower movement in the large intestine leads to increased water absorption from the stool. This causes hard, dry feces and chronic constipation, which greatly exacerbates hemorrhoids.
even the accessory organs, the liver and gallbladder, they feel this hormonal shift too.
They do. The gallbladder becomes hypotonic, so it slows its emptying time, which causes the bile to thicken. This actually predisposes the woman to forming gallstones.
And what's the clinical implication for nurses there?
The reduced gallbladder tone can sometimes lead to bile salt retention, which causes this intense, generalized itching known as pruritus, and that can be extremely distressing for the patient.
Okay, now for the urinary system. Let's start with the most common early and late symptom, frequency.
Urinary frequency starts early. It's driven by hormonal changes and that increased blood volume stimulating the kidneys. It typically gets better mid-pregnancy, only to return in the late third trimester because of the physical pressure from the fetal head when lightening occurs.
And progesterone is added again here.
Again, it relaxes the smooth muscle of the bladder, making the sphincter less competent, so stress or urge incontinence becomes a very common nuisance, especially with coughing or laughing.
The structure of the ureters also changes dramatically, and this is a major nursing concern for infection risk, right?
It's a huge concern. The kidneys and ureters undergo dilation. We call it hydronephosis and hydroeter. This is due to both progesterone's smooth muscle relaxation and the mechanical compression of the ureters by the uterus, and it's often more pronounced on the right side.
And what's the danger of that dilation?
The danger is stasis. The urine sits longer in the tracts, and that gives bacteria ample opportunity to multiply. So it significantly elevates the risk of a urinary tract infection, or UTI, which can lead to serious complications if it's not treated.
Functionally, the kidneys have to filter waste for both mother and fetus. How much does the filtration rate actually increase?
So renal blood flow increases by 50 to 80%, and the glomerular filtration rate, or GFR, increases by a massive 50% starting in the second trimester. This boost is essential for clearing that increased metabolic load.
But this hyperfiltration capacity also creates a kind of clinical paradox when we look at urine content.
It does. Even though the tubules are working harder, they simply can't reabsorb everything because the flow rate is so fast, so substances get spilled.
Like glucose.
Glucose is the classic example. Glycosuria is common because the tubules are overwhelmed, not necessarily because the blood sugar is pathologically high. Similarly, mild proteinuria can occur. This is also why we interpret blood chemistry differently. BUN and serum creatinine levels normally decline during pregnancy because the kidneys are clearing them so efficiently.
But nurses still have to be vigilant.
Absolutely. Increasing proteinuria is still a hallmark sign of preeclampsia, so you can never ignore it.
The skin, or the integumentary system, really acts like a canvas that reflects this hormonal deluge. And it often surprises women who weren't prepared for these cosmetic changes.
That's so true. You see increased circulation, warmth, perspiration, mostly due to the body's elevated metabolism, but the most prominent changes are pigmentary, and they're driven by high estrogen, progesterone, and melanocyte-stimulating hormone, or MSH.
Okay, let's detail those hyperpigmentation patterns.
So you have melasma, or cloasma, which is commonly known as the mask of pregnancy. These are brownish, kind of splotchy patches over the cheeks, nose, and forehead. Then there's the darkening of the linea alba, the midline of the abdomen, into the linea nigra.
Do those go away?
They usually fade postpartum, which is the good news, though melasma can occasionally persist.
We also see those small vascular changes that look a bit like spiders.
Those are spider angiomas. They're tiny red centers with radiating lines. You often see them on the face, neck, or upper chest. We also see redness of the palms and soles, which is called palmar erythema.
And these are just aesthetic.
Purely aesthetic. They're clinically insignificant and they vanish after delivery, just like most of the hyperpigmentation.
And the dreaded striae gravidorum.
Ah, yes, stretch marks. They're basically tears in the connective tissue underneath the skin, and you often see them on the abdomen, thighs, or breasts. We have to manage patient expectations here. They fade from red or purple to silvery white lines, but they are, unfortunately, permanent.
Okay, now, let's look at the musculoskeletal system. The movement and balance of the expectant mother change profoundly.
The change in posture is a direct response to balancing that growing weight. Hormones, particularly relaxin, but also estrogen and progesterone, increase the mobility and relaxation of the pelvic ligaments and joints.
Which leads to that characteristic walk.
The waddling gait, exactly, and significant pelvic instability.
And to compensate for the forward pull of the uterus, the woman has to adjust her center of gravity, doesn't she?
She has to. She leans backward, which increases the inward curvature of her lower spine. That's defined as lordosis. And this postural change is very efficient for balance, but it also increases the strain on the lower back, and it's the primary driver of chronic backache during pregnancy.
What about the abdominal muscle separation?
With that extreme stretching, typically in the third trimester, the rectus abdominis muscles, the six-pack muscles, can separate in the midline. That condition is called diastasis recti. It usually resolves or at least significantly improves postpartum, but it may require some specific core exercises later on.
And let's put one persistent myth to rest. Is the fetus draining calcium from the mother's bones?
Absolutely not. Fetal needs are fully met by the mother's greatly enhanced absorption of calcium from her intestine, which starts to increase early in the first trimester. Maternal bone density is preserved during a normal pregnancy.
Okay, finally, let's explore the driving force behind all these changes, the endocrine system and the incredible power of the placental hormones, starting with the pituitary gland.
So the anterior pituitary increases prolactin production, which is essential for stimulating breast glandular tissue growth and milk preparation. FSH and LH are suppressed. The posterior pituitary releases oxytocin, which is critical for stimulating uterine contractions and the milk ejection reflex.
But its contractile action is sort of held in check during pregnancy.
It's largely neutralized by the high circulating levels of progesterone until labor begins.
And the thyroid speeds up metabolic functions.
Yep, we see glandular enlargement and increased vascularity. The basal metabolic rate, or BMR, increases by up to 25%. And that's primarily driven by the metabolic activity of the rapidly growing fetus and placenta.
The pancreas and glucose metabolism present this really complex hormonal tightrope walk, especially as the pregnancy progresses.
It's so complex. Early in pregnancy, mothers are actually at a risk for mild hypoglycemia because the fetus is pulling glucose and her metabolism is still adapting. But in the second half of gestation, the placenta starts releasing high levels of these powerful anti-insulin hormones. ACS, prolactin, estrogen, progesterone, and cortisol.
And these hormones collectively cause maternal tissue resistance to insulin.
Exactly.
That resistance sounds negative, but it has a very specific critical function, right?
It's entirely purposeful.
Yeah.
This insulin resistance reduces the maternal cell's sensitivity to insulin. That makes less glucose available for the mother and ensures a constant, plentiful supply of glucose is shunted across the placenta to the fetus, which needs a constant stream of fuel.
And if the mother's pancreas can't produce enough insulin to compensate for this resistance, that's when we see gestational diabetes.
Precisely. The maternal pancreatic beta cells have to increase insulin production dramatically, often by threefold, to maintain euglycemia. If that response is inadequate, the mother develops gestational diabetes mellitus, or GDM.
Which is why the screening test is timed for when that resistance is at its peak.
Exactly. The glucose challenge test is timed between 24 and 28 weeks, when this insulin resistance mechanism is most pronounced.
Okay, let's clearly define that critical placental quartet of hormones.
First, you've got HCG, human chorionic gonadotropin. It sustains the corpus luteum until the placenta is ready, around 10-12 weeks, and it's the hormone detected by pregnancy tests. Second, estrogen, which stimulates growth of the uterus and breast ducts and causes all those vascular and pigment changes.
And
Third, progesterone, the pregnancy gatekeeper. It relaxes smooth muscle systemically, so it prevents abortion, it aids lung function, but it also causes all that GI and urinary relaxation. It also maintains the endometrium and acts as an immunosuppressant.
And the final key player, the one we just linked to GDM.
That is HECS, human chorionic somatomammotropin, also called human placental lactogen, or HPL. This is the powerful insulin antagonist. It reduces maternal cell sensitivity to insulin and, critically, promotes the mobilization of maternal fat stores to be used for her energy. It basically switches the mother's fuel source to fat to spare glucose for the fetus.
Let's wrap up this physiology section by revisiting water metabolism and generalized edema.
So total body water increases substantially. We're talking 6.5 to 8.5 liters. And this fluid shift is exacerbated by two things. One, hemodilution lowers the colloid osmotic pressure, which favors fluid leakage into the interstitial spaces.
And
Second, the mechanical compression of pelvic veins by the uterus increases venous pressure in the lower extremities. The result is dependent edema of the feet and ankles, which happens in up to 70% of pregnant women.
this generalized fluid retention isn't just cosmetic, it can cause real discomfort by compressing nerves.
Exactly. The fluid increase can compress the median nerve in the wrist, and that leads to the numbness, tingling, or pain we associate with carpal tunnel syndrome. Nurses have to reassure patients that this condition, while painful, is generally temporary and it resolves within about 3 months postpartum once that fluid load normalizes.
Now that we understand all these internal shifts, let's look at how pregnancy is actually confirmed clinically. The medical community uses a classic 3-tiered classification system: presumptive, probable, and positive. And understanding the limitations of the first two is so essential for avoiding a misdiagnosis.
Right, the classifications move from the least reliable to the most definitive. Presumptive indications are the subjective changes that the woman experiences herself. They're the least reliable because they can easily be caused by other conditions or just stress.
What are the common examples we teach students to recognize in this category?
The biggest indicators are amenorrhea, so a missed period, nausea and vomiting, which usually starts around 4 to 8 weeks, excessive fatigue, increased urinary frequency, the breast and skin changes we talked about, the visible color change, Chadwick sign, and the woman's own perception of fetal movement, which is called quickening.
And quickening is usually felt when?
Usually between 16 and 20 weeks. But you have to remember, a woman might miss a period due to stress, feel nauseous from an illness, or she might perceive gas or peristalsis as quickening.
Okay, so moving up in reliability, we have probable indications. These are objective findings that an examiner can actually document, and they're primarily related to changes in the reproductive organs.
They're strong objective indicators, but they're still not definitive because some conditions, like uterine fibroids or hormone-producing tumors, can mimic them. Key probable signs include abdominal enlargement and the softening of the cervix, which is Goodell's sign.
And what are the key uterine signs we'd be looking for?
We'd look for Hegar's sign. That's the softening and compressibility of the lower uterine segment, or the isthmus, that you can feel during a bimanual exam at 6 to 8 weeks. Another sign, usually detectable near mid-pregnancy, is ballottement.
Can you describe that?
That's where the examiner taps the cervix and feels the fetus float up and then rebound back down. But it has to be differentiated from, polyps or other masses.
We also include the contractions and sounds in this probable category.
Yes, the presence of Braxton Hicks contractions, being able to easily palpate the fetal outline as the uterine wall thins, and the uterine souffle. That's that soft, maternal, pulse-synchronized blowing sound you hear over the uterus, and it's caused by blood flow through the dilated uterine vessels. All probable signs.
Okay, and this is where we have to address the elephant in the room. Why are positive home pregnancy tests only considered probable?
Because they detect human chorionic gonadotropin, or HCG, which is secreted by the placenta. And while they are overwhelmingly accurate in a normal context, the tests can yield false results.
Like a false negative.
Right, a false negative might happen if the test is taken too early before HCG levels are high enough, or if the urine is too dilute, or because of certain medications. But a crucial point is that a false positive can occur due to certain rare tumors, like a hydatidiform mole, or less commonly, specific drugs like tranquilizers or anticonvulsants, even if the body isn't pregnant.
What kind of tests are used to detect HCG in a clinical setting?
The rapid common one is the agglutination inhibition test, which uses antibodies to detect HCG quickly. For highly sensitive early detection, we might use a radioreceptor assay, which can detect tiny amounts of HCG very early, sometimes as soon as 6 to 8 days after conception.
And that's useful for?
That sensitivity is often used to diagnose very early ectopic pregnancies or for quantitative monitoring.
Finally, we reach the positive indications. These are the findings that are caused by pregnancy and only by pregnancy. What are the 3 definitive signs?
The 3 definitive signs are, first, auscultation of fetal heart sounds. We can detect this with an electronic Doppler as early as 9 weeks, and with the non-electronic stethoscope by 16 to 20 weeks. The rate has to be clearly differentiated from the maternal pulse or the umbilical cord pulse, the phonic souffle. It has to be between 110 and 160 beats per minute.
Okay, that's one. Second,
Fetal movements felt by an experienced examiner. This has to be clearly distinguished from the mother's subjective quickening or from palpating intestinal peristalsis. It has to be a clear, definitive kick or movement felt by the provider.
and third, the most modern confirmation.
Visualization of the fetus. A transvaginal ultrasound can confirm the presence of a gestational sac as early as 3 weeks of gestation and can confirm fetal viability and a heartbeat by about 8 weeks. This is the absolute gold standard for a definitive diagnosis.
Once that pregnancy is confirmed, the structured framework of antepartum care begins. The goal is to optimize health and manage risks long before delivery, and ideally, this process starts with preconception care.
Preconception care is such a high priority now because many critical fetal organ systems like the neural tube develop before a woman even knows she's pregnant. We identify and manage pre-existing risks like uncontrolled diabetes, hypertension, substance use, and encourage positive health behaviors.
And the primary public health recommendation here relates to a really crucial vitamin.
Folic acid. It's essential for preventing neural tube defects. The updated recommendation states that all women of childbearing age should consume 400 to 800 micrograms, or 0.4 to 0.8 milligrams daily, starting at least 1 month before conception.
And the dose is higher for some women.
Much higher for women with a history of neural tube defects. They need 4 milligrams daily to maximize protection.
The initial prenatal visit is lengthy, and it's all about establishing baseline data through a comprehensive history. We need to solidify the terminology used to describe a woman's obstetric history.
This vocabulary is key to medical record keeping. Gravida is simple. Any woman who is or has been pregnant, regardless of the outcome or the duration. So primigravida means first pregnancy, multigravida means 2 or more.
And para is where we need to be really precise.
Para refers only to the number of pregnancies that have reached 20 or more weeks of gestation, whether the infant was live or stillborn. A null para has never completed 20 weeks. A primipara has had 1 delivery at 20-plus weeks. A multipara has had 2 or more.
And crucially, the number of fetuses in a single delivery.
Does not change the para count. Twins, triplets, that's still 1 para event.
To provide a full snapshot of the history, we use the 5-digit code GTPAL.
Where the acronym stands for G is gravida, or total pregnancies. T is term births, so 38 to 42 weeks. P is preterm births, from 20 to 38 weeks. A is abortions, spontaneous or elective, before 20 weeks. And L is living children.
Let's use a challenging scenario to make sure we submit this. A woman is currently pregnant with twins. She previously had 1 spontaneous abortion at 12 weeks, and before that, she delivered a single baby at 36 weeks. What is her GTPL?
Okay, let's track it. She is pregnant now, so that's her 3rd pregnancy. G is 3. The delivery at the 36 weeks adds 1 to P for preterm, so P is 1. The abortion at 12 weeks adds 1 to A, so A is 1. And the child born at 36 weeks is her 1 living child, so L is 1.
And T.
T is 0. She hasn't had any term deliveries yet, so her current GTPL is 30111.
Right.
And if she delivers the current twins at 40 weeks, her new GTPL would be 41113. The key is just understanding how those definitions stick.
Once we have the history, we calculate the estimated date of delivery, or EDD. What's the standard traditional rule for that?
We use Nagel's rule. This involves taking the first day of the last normal menstrual period, or LNMP, subtracting 3 months, adding 7 days, and then correcting the year. This gives us a standard EDD, although confirmation via ultrasound is often used to ensure accuracy, especially if the LNMP is uncertain.
The physical exam establishes baselines. How should vital signs, particularly BP, be measured to ensure accuracy in a prenatal setting?
BP has to be measured consistently.
Yeah.
The woman should be seated with her arms supported, and the nurse must use the same arm and position for every subsequent visit. We use Karatkof's 5th phase, the disappearance of sound, to record the diastolic pressure. Immediate evaluation is needed if DP hits or exceeds 140/90.
And we also establish baseline height and weight.
Right, to calculate BMI, because weight extremes, being underweight or obese, are strong indicators of high risk.
The urinalysis is performed at every single visit, and it provides quick, essential data. What are the key findings we're tracking there?
We're checking for 4 things. First, protein. Trace amounts can be normal, but increasing protein suggests preeclampsia or underlying kidney disease. Second, glucose. Small amounts can be that normal physiologic spilling from the high GFR, but significant amounts are highly concerning for gestational diabetes.
And the other 2?
Third is ketones, which indicates heavy exercise or, more often, inadequate calorie or fluid intake. And fourth, bacteria or nitrates, which are crucial indicators of a potential UTI risk. That requires treatment due to the risk of pyelonephritis and preterm labor.
Beyond the baseline vitals and urine checks, what laboratory tests are performed initially, and what's the nursing significance of each?
The initial blood work is a comprehensive screen. We determine blood grouping and Rh factor to screen for potential maternal-fetal incompatibility that might need an intervention like RODAM. The CBC screens for anemia and infection. VDRL-RPR screens for syphilis.
And the rubella titer.
We check the rubella titer. If the titer is 1 to 8 or less, the mother isn't immune and she'll need immunization postpartum, since the live virus vaccine is contraindicated during pregnancy. We also screen for hepatitis B, HIV, and potentially genetic diseases like Tay-Sachs or sickle cell anemia based on risk factors.
Moving past that initial visit, what's the traditional schedule for subsequent prenatal assessments?
The schedule is dictated by time and risk. For an uncomplicated pregnancy, visits are every 4 weeks from conception to 28 weeks. Then they increase to every 2 weeks from 29 to 36 weeks. And finally, weekly from 37 weeks until birth.
And there are alternative models now, too.
Right, models like centering pregnancy, which uses group sessions for peer support and shared education.
During these visits, we're continually monitoring weight gain and the single most reliable non-invasive assessment of fetal growth.
That would be the fundal height measurement. The woman has to empty her bladder before you do it. The nurse measures from the top of the symphysis pubis to the top of the fundus. From about 16 to 18 weeks until 36 weeks, the measurement in centimeters should approximately correlate with the weeks of gestation.
Centimeters should equal weeks.
Roughly, yes. From a sling should equal weeks.
So if the fundal height is off, either too large or too small for gestational age, what does that signal to the nurse?
It immediately triggers a differential diagnosis and further assessment. If it's too small, it could mean the EDD is wrong, or fetal growth restriction, or low amniotic fluid. If it's too large, it could suggest an incorrect EDD, a multifetal pregnancy, excessive amniotic fluid, or even uterine fibroids. This simple measurement provides crucial insight.
Later in pregnancy, physical maneuvers become helpful in determining the baby's position.
We use Leopold's maneuvers, which is a systematic 4-step palpation sequence of the abdomen. This allows the nurse to determine the fetal lie, presentation so head or breech first, and position, which is vital information for planning the delivery.
And we're also monitoring FHR and fetal activity.
Right. Fetal heart rate should stay between 110 and 160 DPM, and we teach kick counts in the 3rd trimester, a reliable, simple method for the mother to monitor fetal well-being every day.
And what are some of the critical risk management screenings done in the latter part of pregnancy?
The glucose challenge test is done at 24 to 28 weeks. For Rh-negative women who are unsensitized, meaning their antibody screen is negative, we administer Rhe immune globulin, or RhoGAM, prophylactically around 28 weeks.
And that's to prevent?
To prevent the formation of anti-Rh antibodies that could harm the fetus. And in the last month, we often do internal pelvic exams to track cervical changes and fetal descent.
We must also constantly assess for high-risk factors. Can you give us some examples of those risk categories and their consequences?
High-risk factors are broad. You have demographic risks, like age extremes, so under 16 or over 35, or low socioeconomic status, which impacts access to care. Obstetric risks are powerful predictors. A history of previous preterm birth significantly increases the risk of it happening again, and existing medical conditions are critical. Chronic hypertension or uncontrolled diabetes dramatically increase the risk of fetal anomalies, preeclampsia, and large for gestational age infants. Recognizing these flags immediately means a more intensive prenatal schedule.
We mentioned that a fundal height that's 4 centimeters or more larger than expected might suggest a multifetal pregnancy, which is then definitively confirmed by sonography. For the nurse, what is the magnified burden placed on the mother's physiology when she's carrying twins or more?
All the physiologic changes are significantly magnified. This is because the maternal body is supporting 2 placentas and 2 metabolic systems. For example, the total blood volume increase, which is 40 to 50% for a singleton, increases by an additional 500 milliliters or more for twins.
Which means a much higher cardiac workload.
A much higher cardiac workload, and it leads to earlier, more severe fatigue.
And the sheer physical size must just be incredible to manage.
It's physically taxing. The uterus can reach volumes of over 10 liters and weigh more than 20 pounds. This profound overdistension leads to greater elevation of the diaphragm, which intensifies respiratory difficulty and dyspnea much earlier in the pregnancy.
I would assume the risks that are associated with vessel compression are also dramatically increased?
Absolutely. The weight causes earlier and more severe supine hypotensive syndrome and significantly worse venous stasis, so you see much more pronounced dependent edema, severe varicosities, and chronic hemorrhoids. Also, the pressure on the GI tract often results in more severe and persistent nausea, vomiting, and constipation, sometimes pushing women toward hyperemesis.
So how does the antepartum care model shift for these high-risk pregnancies?
The frequency of prenatal visits increases immediately. The focus shifts to extreme vigilance for complications, which are far more common. Severe anemia, pregnancy-induced hypertension, gestational diabetes. The most significant concern, though, is preterm labor and birth, which is the leading risk for multifetal infants.
Nutrition and rest must be specifically adjusted for that greater demand.
The caloric, protein, iron, vitamin, and especially folic acid requirements are all higher. For women carrying twins, the recommended total weight gain jumps significantly, 17 to 25 kilograms, which is 37 to 54 pounds or even more, depending on her pre-pregnancy BMI.
And rest becomes even more critical.
It's critical to optimize uteroplacental perfusion. And because of the inherent risk, tests of fetal well-being, like non-stress tests or biophysical profiles, are often performed twice weekly in the third trimester.
This section is really the core of patient-centered nursing. When a patient comes in, she wants advice on how to survive the next 9 months. Our interventions for these common discomforts have to be practical, specific, and based on sound rationale.
Exactly. The nurse's primary role here is education and supportive care, focusing on achieving that patient goal of readiness for enhanced childbearing process. Let's start with the famous one, nausea and vomiting, or morning sickness.
It affects 70 to 80% of women, typically disappearing around 14 to 16 weeks. We link it to high HCG, estrogen, and periodic hypoglycemia. What are the most effective teaching points?
We combat the hypoglycemia. Advise dry crackers or toast before getting out of bed in the morning to stabilize blood sugar. Then small, frequent meals every 2 to 3 hours that are rich in protein and complex carbs.
And drinking fluids.
Crucially, advise drinking fluids separate from meals because mixing food and large fluid volumes can increase stomach distension and make the nausea worse. A protein snack before bed and taking prenatal vitamins with food or at bedtime can also minimize gastric irritation.
Next up, heartburn, or pyrosis, which is caused by that LES relaxation and stomach displacement. What's the nursing rationale for prevention?
The rationale is both mechanical and chemical. Mechanically, eat small, frequent meals, avoid large meals, and don't lie down or bend over right after eating. Elevating the head of the bed or using extra pillows helps gravity keep the stomach contents down.
And chemically.
Avoid the known triggers like fatty, acidic, or spicy foods.
If the patient needs an antacid, what's the crucial safety advice a nurse has to provide?
Advise using sodium-free antacids. The mother is already retaining a significant amount of fluid, and antacids with sodium, like Alka-Seltzer or baking soda, can exacerbate that fluid retention and potentially lead to complications like high blood pressure or excessive edema.
Backache is nearly universal because of the progressive lordosis and relaxed ligaments. What are the key exercises we can teach to correct posture?
The primary focus is improving core stability and correcting that pelvic tilt. So we teach good body mechanics. Squat, don't bend, avoid high heels. The 3 essential exercises are tailor sitting cross-legged, which stretches the inner thighs and hip joint shoulder circling to improve upper back posture, and the pelvic tilt or pelvic rocking.
Which is often done on hands and knees.
Yes, and it strengthens the abdominal muscles and reduces that lumbar curvature.
What about that sudden, sharp, temporary pain often described on the right side, round ligament pain?
That pain is caused by the sudden stretching or spasm of the ligament that's supporting the uterus. The intervention is immediate counter movement, so advise the woman to avoid sudden movements, and if the pain hits, to bend toward the pain, squat down, or bring her knees up to her chest to relax that taut ligament. Heat can also help.
For urinary frequency and stress incontinence, we have a simple yet powerful exercise regimen.
Kegel exercises are paramount. The rationale is to strengthen the pelvic floor muscles that are weakened by progesterone and the weight of the uterus. You teach the technique. Contract and hold the muscle group around the vagina and urethra for 10 seconds. Relax for 10 seconds and repeat that 30 times a day.
And there's a critical safety point there.
A critical safety point. Advise the woman not to routinely perform Kegels while starting and stopping the flow of urine. This can actually lead to urinary retention and increase the risk of a UTI.
Varicosities and hemorrhoids are caused by venous compression and stasis. How do we teach patients to minimize this risk?
We have to optimize venous return and minimize pressure. So advise avoiding prolonged standing or sitting. restricting clothing that constricts the legs or waist, and avoiding crossing the legs. The most effective intervention is frequent rest with her legs elevated above the level of her hips.
What about support hose?
If support hose or compression stockings are used, the nursing teaching must stress applying them before getting out of bed in the morning when the degree of dependent edema is lowest. For hemorrhoids, high fiber and water intake to prevent straining is key, along with local treatments like tepid baths and witch hazel compresses.
Constipation requires a comprehensive lifestyle approach to overcome that slowed motility and increased water absorption.
The teaching has to focus on the three pillars: fluid, so at least 8 glasses of non-diuretic liquid daily; fiber, from high-fiber fruits, vegetables, and whole grains; and fitness, so regular low-impact exercise like walking or swimming. We also teach them to establish a regular elimination time, ideally about an hour after a meal, to leverage that natural gastrocolic reflex.
Finally, those painful leg cramps, which often strike at night.
While they're sometimes linked to a calcium-phosphorus imbalance or maybe low magnesium, the most immediate and effective relief technique is counter-stretching. Keep the leg extended and manually bend the foot towards the body dorsiflexion.
And that stretches the calf muscle.
Right, relieves the spasm. Yeah. And for prevention, frequent leg elevation helps.
Beyond discomforts, let's touch on general health promotion and safety. We have to address bathing and hyperthermia risk.
Bathing is safe and it promotes comfort. However, maternal hyperthermia, especially in the first trimester, carries a risk of neural tube defects and other fetal anomalies. So advise strict limits. No saunas for over 15 minutes and no hot tubs over 10 minutes, and make sure the head and upper chest are kept above the water level to cool the core.
And douching.
Women should be strongly advised against douching despite the increased discharge. It can disrupt the vaginal flora and increase the risk of infections like bacterial vaginosis or BV, which is linked to preterm birth.
What's the rule of thumb for exercise in an uncomplicated pregnancy?
Moderate exercise 30 minutes or more daily is highly encouraged. Walking and swimming are ideal. The key safety restrictions are to avoid strenuous or contact sports and never perform exercises in the supine position after the first trimester because of the risk of supine hypertensive syndrome.
And the woman must stop exercising immediately if
She feels pain, sees bleeding, or notices a decrease in fetal movement.
travel is safe, but it requires precautions to counter that hypercoagulable state in venous stasis we talked about earlier.
For car travel, the woman has to stop and walk for about 10 minutes every 2 hours to promote circulation and decrease the risk of thrombosis. Seatbelt use has to be taught correctly. The lap belt snugly under the abdomen across the hips and the shoulder belt diagonally across the chest. Plane travel is generally safe up to 36 weeks if the pregnancy is uncomplicated.
Let's quickly review immunization safety.
Live virus vaccines, MMR, varicella smallpox, are strictly contraindicated due to potential teratogenicity. Inactivated vaccines like the flu shot are safe and often recommended. The CDC recommends the Tdap vaccine in the late second or third trimester to give passive immunity to the newborn against pertussis, or whooping cough.
Okay, finally, the critical safety alert. What are the non-negotiable warning signs that require an immediate call to the provider or a trip to the hospital?
These are the red flags we teach every single patient: vaginal bleeding or the sudden escape of fluid from the vagina; excessive or sudden swelling of the face or fingers, which suggests severe fluid retention and preeclampsia; a persistent severe headache or visual disturbances, like blurred vision or spots, which are also signs of preeclampsia;
And what else?
severe abdominal or epigastric pain, which could be a sign of placental abruption or HELLP syndrome; chills or fever, which suggest infection; persistent vomiting, which is a risk for hyperemesis gravidarum; painful urination, which could be a severe UTI; and any sudden, significant change in fetal movement. Nurses have to empower patients to recognize and report these symptoms instantly.
Beyond the immense physical undertaking, pregnancy is a profound psychological and developmental transition. It's marked by specific emotional tasks in each trimester. The mother transitions from focusing on herself to focusing on the fetus to preparing for the birth and the parenting role.
The psychological focus changes so dramatically,
Yeah.
and it's based on the physical reality of the pregnancy at each stage.
So in the first trimester, the physical changes are subtle, and the primary psychological focus is on the self.
This stage is really dominated by uncertainty and ambivalence. The woman is focused on just confirming the pregnancy, and she often deals with conflicting feelings, even if the pregnancy was planned. She might worry about her ability to parent, the impact on her life, all the new responsibilities.
And the physical symptoms?
The physical symptoms, the nausea, the fatigue, the mood swings, They confirm the reality of the process, but the fetus itself remains a very abstract concept.
The emotional ability here, the mood swings can be so intense. What is the nurse's key intervention?
Reassurance and validation. The mood swings are genuine. They're often driven by the rapidly fluctuating hormones and just sheer physical exhaustion. The nurse has to normalize these experiences and reassure the woman that her feelings of uncertainty and fatigue are common and expected developmental tasks of this early phase.
Then the second trimester is often characterized as the golden period, where the primary focus shifts completely to the fetus.
And this shift is driven by the undeniable accumulation of physical evidence. Quickening, that sensation of fetal movement, and seeing the fetus on an ultrasound make the baby real and separate from the mother. This is when early bonding truly accelerates.
So her motivation changes from just managing her own symptoms to making sure the baby is healthy.
Exactly. She transitions to focusing on diet, developmental information, and protected behaviors. And this intense focus often manifests as narcissism and introversion, a preoccupation with her body and herself, but primarily as a vehicle to protect the fetus. She might lose interest in outside activities or work, which can sometimes be isolating if it's not understood by her partner or family.
Body image shifts are rapid and can be a source of stress, too.
Oh, definitely. The rapid changes in size, contour, pigmentation, they cause profound body image concerns. While many feel pride and excitement, others really struggle with feeling awkward, heavy, or unattractive. The nurse has to validate those feelings, provide realistic reassurance that many changes are temporary, and encourage the mother's acceptance of her changing self.
And sexual responsiveness often peaks during this trimester. Why is that?
It's a combination of things. Increased pelvic vasocongestion from all the high blood volume and hormones, coupled with the resolution of that first trimester nausea and the psychological relief of not needing contraception. It often leads to increased libido, greater lubrication, and potentially more intense orgasms.
So it's important to teach that intercourse is safe.
Nurses have to proactively teach that intercourse is safe for an uncomplicated pregnancy, right up until term, unless there's a risk for preterm labor or vaginal bleeding or an incompetent cervix.
Okay, finally, the third trimester. The focus shifts to vulnerability and preparation.
This stage brings increased anxieties. The woman experiences these intense feelings of vulnerability, fearing loss, injury, or harm to the baby. This might manifest as hypervigilance, avoiding crowds, and having vivid nightmares about the infant's safety or well-being.
Her dependence on her partner often increases sharply here.
She seeks security and constant assistance from her partner, and she might become irritable or demanding if the partner fails to provide that sympathetic support. And compounding this, many women experience immeasurable difficulty with concentration or sustained attention.
Which means nursing teaching has to be.
Particularly clear, focused, and concise.
And the final psychological task is preparation for the delivery itself.
Her focus now fully shifts from being pregnant to having the baby. The feelings of separateness from the fetus increase. Her anxieties center entirely on labor, knowing when it's starting, coping with the intense pain, and making sure they get to the hospital in time. This is why women diligently attend childbirth education classes and practice coping mechanisms during this final stage.
What an incredible deep dive into the complex synergy that drives a healthy pregnancy. We've tracked the total systemic overhaul from that 500% increase in uterine capacity to the 50% boost in GFR. All of it orchestrated to prioritize fetal development and support maternal health.
The greatest nursing takeaway, I think, lies in recognizing the predictability of these changes. Safe and effective care hinges on distinguishing the normal physiological adaptations, like the systolic murmur, the pseudoanemia, and the physiologic glycosuria from the abnormal pathology, like increasing proteinuria or severe epigastric pain.
Right, and the predictability of fundal height is your non-invasive metric for fetal growth.
Exactly.
And practical patient education is paramount. We can't just tell patients what to do, we have to explain the rationale. Knowing that heartburn requires sodium-free antacids because of the fluid load, or teaching dorsiflexion for a leg cramp, or stressing the correct position for sleeping to avoid supine hypotension, these specific, detailed interventions build trust and ensure safety.
And finally, recognizing that psychological roadmap, validating the ambivalence and fatigue of the first trimester, supporting the introversion and bonding of the second, and addressing the vulnerability and preparation fears of the third, that allows you to provide true holistic care. Patient education and dynamic risk assessment are constant priorities that link every single body system together.
We've explored the dense, fascinating architecture that maintains a successful pregnancy. This foundational knowledge really empowers you to understand the why behind the symptoms and move beyond merely documenting them. So now, as you reflect on this massive amount of material, which specific physiological adaptation, perhaps the hypercoagulable state's dual nature or the function of HCS and fuel switching, surprised you the most? And how will you use that refined insight to build rapport and deliver the most effective, personalized education to your first prenatal patient?
Thank you for joining us for this deep dive.
We'll catch you on the next one.